Good afternoon. I want to welcome everybody to the second half of our session today. I'm Dr. Christopher Lathan, and I'm a medical oncologist who focuses specifically on lung cancer. I am also the Chief Clinical Access and Equity Officer at the Dana-Farber Cancer Institute. And today, what we want to do in this session is really set up the conversation for our speakers coming next to really delve a little deeper into the ethics of using big data in medicine. And what I plan to do today in this overview slide is really talk about big data and equity, and that's one of the issues here, and give you some examples. Talk about medical hubris, because I really feel that this is one of the areas that gets us into trouble as we think about using our tools. We get very excited about the use of our technology tools, and we think that the new tools might be able to alleviate some of the other problems. And then the other question is to ask ourselves, how do we protect communities, and think a little bit about prospective community engagement, and some of the ways I think that this can be mediated, which is through transdisciplinary research teams and end with a call to action. So I start here with our enemy here, Joe Camel, in thinking about tobacco and lung cancer. And so certainly all of us who are watching this know, and here for this conference, we know what we're talking about here, about lung cancer screening and underutilization rates and the differential impact based on race and class and region. And I think you're going to see a slide in a minute where the impact of the pandemic, I think, is going to worsen these issues for us in lung cancer screening. And the big question is, can we use technology to level the playing field? Dr. Mulshine always says, he really has an approach of thinking about how we can use the technology to allow people to take back, the control of this and allow people to really advocate for themselves. And I don't want to forget to talk about, the targeting of a historically marginalized community. So yes, for Black and Indigenous, blue collar folks of all races, and also the LGBTQ community with tobacco and tobacco advertising. So we know that specific marginalized communities are being targeted. This slide is really just showing what American Cancer Society is thinking about as far as how the pandemic could be worsening our issues with screening. And certainly the data is still mixed. There are some early studies that are showing that there are issues with screening and screening rates, and that's going to lead to mortality issues. As we know in lung cancer, we are particularly vulnerable here. And so how we utilize our screening modalities, how the screening modalities have been impacted by pandemic is going to make a situation that's already bad much worse. So pivoting to the topic of today, which is really, thinking about applications of AI and big data, I really thought this was an excellent illustrative slide. It's really taken from Dr. Delami's Artificial Intelligence and Big Data paper. And I thought it was a good illustration of where we are in healthcare. We know that big data has many applications in medical care. We know that physicians tend to be overly optimistic about the use of technology. If you have a new tool, whether it's a robot surgeon or a new data method, we tend to be very excited about how this can fix the problems of the past. We don't tend to think about unintended consequences in the future. And I think as we think about evidence-based data mining and the combination of patient-reported outcome data and how data mining plus evidence-based data and patient-reported outcomes, how do these all merge together? And I want us to think about that as we continue to move forward into this, big data AI algorithm world, not to forget about evidence-based data in the present and also about patient-reported outcome data, and that the historically excluded communities are particularly vulnerable to exploitation with these tools. And I'll get into that in a little more detail. Could they be protected? Well, there's some federal protections. They are a little weak, meaning that they're basically based off the 14th Amendment, and local states can have a lot of say in how individual data and data mechanisms are used. So I put at the bottom here a lot of the references for this, but certainly this is a new frontier. And I think a lot of times we don't really know the proprietary elements of our algorithms. And this is another great illustration. We're really focusing in our lung cancer screening discussion on the diagnostics data area there that I've highlighted in the box. And I bring this up because most AI algorithms tend to be proprietary. And unlike when I do large database analysis, someone can ask me for my code and I can show them what assumptions I've made. Well, what we know is when you're looking at these AI algorithms, we don't always know the assumption. Sometimes that's proprietary and it's not able to be shared. And that really means that we might not be able to see the bias that's built in. So let's just get to that, right? Let's talk a little bit about how structural racism and classism, this is not individual acts. We tend to think of them as individual acts, but the truth is it's really hard to understand how our data is impacted by the structure of our society, especially if you're not impacted by it, right? So while these AI algorithms are helpful, they've been shown sometimes to inadvertently be discriminatory. And I think, when you look at facial recognition software, when you look at vocal recognition, this is well documented in things that people use every day. All right, Chris, well, that's fine, but what about looking at this in governmental arenas and specifically getting into medicine? Well, before we get to medicine, we know that this big data usage and the AI algorithms often being touted as objective have been used to try to rectify currently existing non-egalitarian structures. So insurance, e-scores for loans, IQ personality tests that people do pre-job, and criminal sentencing software, all of these things were done really to try to eliminate bias. But what we have found is that actually, because of the implications and because of the use of the built environment variables that they put in, it unintentionally built in bias to all of these. And it's very hard to get people to admit it and recognize it because, again, you don't have access to the proprietary AI algorithms and be able to understand what the problems are to make adjustments. So historically marginalized communities also have a good reason to question the intention of the medical community regarding the data. Let's be honest here, right? We have a lack of representation in cancer genome data sets. There's been careless stewarding of the data and tissue for marginalized communities. We don't have to get into Henrietta Lacks, Tuskegee. There's a lot of things there that the community knows about that is not in the distant past, but in the recent past. And then, just look at some of the data sets specifically. There's a very Eurocentric focus in germline data sets. An example of my own life, my mother had early onset dementia. And when she passed, many of my medical colleagues asked me, hey, are you going to get a test for that? Turns out that the tests for early dementia are really based off of European subsets, and they're not validated in African Americans. You don't really know that unless you delve deep into the data, but that test is not useful at all for someone like myself or for millions of people who don't come from a very specific background. And so I put the caution at the end of what I call race medicine to remember that race is a social construct, not a biologic construct. And what we're trying to do when we talk about big data is make sure we're dealing with the variables that are appropriate. So lung cancer screening is important. The use of AI might be helpful, but without real efforts to combat bias and acknowledgement of some of the past issues, we will do the same damage. And if you have a moment to read The Weapons of Math Destruction by Cathy O'Neil is a great book. I also put in a couple other books here that I got a lot of the information from. It's a really good, sobering way to think about how these things can impact us. And intent can be separate from impact. You can have good intent and still have an impact that puts people at risk. Okay, so transdisciplinary approaches, I think, are the best way to deal with inequity in big data. And again, we're going to be leading into our two speakers. One is going to be talking about this from the advocacy community, and the other looking at an intervention that utilized EMR and in the community, I think, in a way that is really a good example of how to put some of these tools together. So there's some perspective opportunities here. You want to ask these questions as you use your tools, your AI tools and your big data tools. Does the tool increase the agency and self-determination of historically marginalized groups? Is the data representative and relevant to our actual society as it is today? Do the participants have agency? So if you're collecting health information, if you're collecting information that is shepherded, is it shepherded by the community? Is it owned by someone else? And have we engaged with the shepherds of that data and the participants of that data? And was the community engaged from the start if you're building this tool from the ground up? And then consciously think about diverse transdisciplinary teams involved with the building of your research tool. So cross-cutting technical, clinical, translational, basic science, social science, and policy. You really want to focus there. It's the only way to keep us from making the same mistake and getting lost again, right? The only way to make sure you don't get lost again is take a different path. And we must do that. So just want to end last two slides thinking about transdisciplinary research and thinking about it very specifically. Transdisciplinary research is really a mode of collaboration where people are operating outside of their own disciplines. It's not just a bunch of docs getting together, a bunch of engineers getting together. It's really taking social scientists plus an engineer plus a medical doc plus a structural person or a data coder, and really thinking about things outside of their usual intellectual space. And it's hard. It's very, very difficult. And I think if you want to think about how we can protect our communities as we move forward, ask yourself a question. Have you engaged with the communities at the start of your data project? Have you engaged faith-based groups, large employers, community leaders, and policy experts? Do you have the desire to really correct the algorithms and acknowledge the bias? I think if you don't really have the desire to do that, because it's going to be hard, it's going to require forethought and time, then are you really going to protect the community? And build your transdisciplinary team. Ask yourself, is your team inclusive? Technical skills, perspective, and is it representative of marginalized communities? Is there voice for people who could be affected by the big data, by the algorithm? And do you really want this authentic transdisciplinary output into your data sets and AI algorithms? I think you should, but if you don't, then it's something that we need to really think about. And I wanted to, this is not easy. It's going to require us to have a little umph and determination and will and spend some resources, right? And there's some great data on this that was published by Gellert and thinking about transdisciplinary challenges and why it's important. I will leave you with the idea that it's not easy, but it is necessary. And so last slide here is my call to action before we get to our speakers. Know that our medical research has often been used knowingly and unknowingly to categorize and subjugate immigrants, poor, and descendants of slaves in the US. That the research has not been agnostic as much as we'd like to think so, and until very, very recently has overtly frowned upon the social justice approach in medicine. And the legacy of this remains today. Big data and AI are the new frontier. Have we remembered any of these lessons from the past? And this picture that you see over there is from 1963, when people were really protesting the AMA's stance, which didn't want to desegregate hospitals and move forward with Medicare. So if you haven't already, I recommend folks listen to the 1619 podcast, episode 4, When the Bad Blood Started, about medicine. And I think this is a good way to frame the conversation and our speakers that are coming forward. So thank you very much for your time and your attention.